Good morning, everyone. I am Guyana Thompson, a bachelor's in psychology student at the University of Guyana. And I'm sure that we've all experienced some sort of anxiety before. And well, within reason sometimes, did I get that promotion? Did my grades did I do good in my last exam? But now try to think of children who have intense, excessive, and persistent worry and fear about everyday situations. These children most likely suffer from anxiety disorders. These feelings of anxiety and panic interfere with their daily activities and are difficult to control. So how do we help them? That question will be answered today as we receive a direct look at clinical training, assessment, and management of anxiety disorder in pediatric primary care. Our illustrious speaker has over 28 years of experience in clinical practice, academic psychiatry, research, and public health. He completed his MD at Yale University, and he is the holder of a master's in public health, specializing in child psychiatry research and mental health statistics. He has devoted in studies examining the lifelong effects of trauma on children's mental health as Associate Director of the Global Psychiatric Epidemiology Group at Columbia University. After the tragic 9/11 events, he co-directed the Trauma Studies and Services Division at the New York State Psychiatric Institute. He has been extensively involved in treating victims of 9/11 and their families in doing research on the effects of the 9/11 attacks on the survivors and first responders, and in training clinicians in cutting-edge treatments for PTSD and complicated traumatic grief. Ladies and gentlemen, it is an absolute pleasure to present to you a mover and shaker in the field of psychiatry, Dr. Lawrence Amsel.
Good morning, everybody. Thank you for that very, very warm welcome and for that, that great introduction about my skills. And what that has done is raised my anxiety a great deal about giving this talk because you set the bar very high. But what we'd like to do this morning is to talk about how you manage and assess and manage and treat anxiety disorders in the primary care setting. But this talk is not only for primary care doctors, it's for anyone who is interested in anxiety and its nature. Every clinicians, non-clinicians, anyone who is interested in mental health, I hope will benefit from this talk. I'd like to mention, in addition to the Global Psychiatric Epidemiology Group at Columbia and our association with this Guyanese project, I would also like to mention and give a shout out to the Reach Training Institute, where I have been working with them for the last 20 years. And the Reach Institute's primary goal is to reach out to primary care clinicians and to train them to handle mental health cases in primary care. We know that in the US, in most states, there are very few child psychiatrists. And we have recognized at the Reach Institute and at GPEG, and GPEG is, for those who don't know, is short for the Global Psychiatric Epidemiology Group at Columbia, headed by Dr. Christina Hoven. We've recognized that we need to train more clinicians, and that is primary care doctors, family practice doctors, pediatricians, and others in how to handle mental health care. We cannot rely only on psychiatrists, also social workers. So get the full clinical benefit from all those clinicians out there. We've trained over 5,000 primary care clinicians. And again, as I say, that ranged from pediatricians to family practitioners, to nurse practitioners, to just registered nurses who also participate in this. The program consists of an intense 3-day workshop, and that's followed by virtual rounds. Those are small group discussions of actual cases in the primary care clinician's practice. So that primary care clinician is practicing, and they have cases that come up, and when the cases come up, and they can bring them in to this discussion that takes place every 2 weeks for 6 months. And so it is like clinical training in that the 10 of us on that small group training will discuss that case in great detail. By the end of that, the primary care clinician not only has knowledge, but skill and experience having dealt with individual cases, and feels much more confident in their handling of mental health cases. There's also CME credit available for every hour that people spend on this program. During this Guyanese conference, I'm going to give 3 of the 15 modules in that training. I've already spoken about depression. Today, I'm going to talk about anxiety. That's module 2. And the third module is going to be tomorrow morning at the same time. And we're going to talk about bipolar disorder and psychosis. That's 1 unit. We'll do that together. We hope that we can bring the full version of this training to the Guyanese clinicians in the coming years. And we hope that GPEG can partner, as we are partnering on so many other projects, to accomplish that. So I'm really looking forward to being able to do that. What are our learning objectives this morning? We want to review how to screen and assess anxiety disorders in the primary care setting. We want to be able to learn how to score and interpret standardized screening anxiety questionnaires, as well as questionnaires that are specific to anxiety. And we want to discuss the evidence-based psychotherapy and pharmacology that are now considered standard of care for anxiety disorders in the primary care setting. Well, what are the basic anxiety disorders that are now considered in the DSM-5? And this has changed with the DSM-5. So it's very interesting. We have separation anxiety disorders, and that is often not a diagnosis we see in adults. However, our team has found that after 9/11, the children who were exposed to 9/11, even in adulthood, they have separation anxiety disorder, which is somewhat rare in like I say, in adults, but not rare in kids. Selective mutism, and that's where there's no physiological basis for the mutism, but some children are mute, and it turns out because they're anxious, they can't speak. There's panic disorder, and there's a good amount of literature that says that panic disorder could be a high risk factor for suicide. It is so uncomfortable to go through a panic attack. If any of you have ever gone through a panic attack, you know that it's just absolutely the most awful experience. And among children, it's absolutely terrible. Among adults, they often end up in the emergency room thinking they're having a heart attack, thinking that they're dying. So it's very important for emergency room doctors to be aware of panic disorder, which can sometimes present, as I say, in adults, it could present as cardiac issues. Specific phobias means that you have a fear of something, fear of snakes, fear of particular things, bugs, mice. Some people have very specific fears of this. Why is that so bad? Why don't they just avoid that thing? Well, sometimes they can't avoid it, and so they have to avoid lots of things. If people are afraid, for example, right now in New York City, there's lots of rats post-COVID. And if people are fearful of those rats, some people are afraid to actually go outside because they're going to run into a rat. Social anxiety disorder is what I'm having now. That is related also to performance anxiety. And that is that when you fear, you're in a situation where there's a potential to be judged, and you fear that situation. So that's called social anxiety disorder. Agoraphobia is fear of the agora. The agora is the public square. So those are people who are terrified of being in a public square, subways, buses, busy streets are very, very, very troublesome for them. Then there's also generalized anxiety disorder, which is where people are just very nervous people. These are the people who worry about everything, and they do a mental thing called catastrophizing. Catastrophizing is where if there's possible outcome to a situation, they are sure that the worst possible outcome is the one that will happen to them. So that's generalized anxiety disorder. Okay, now the other disorders which are related to anxiety disorders, these used to be part of the anxiety chapter in the DSM and the older DSMs, but now they've been separated out. Post-traumatic stress disorder, which is something that I spent a lot of time with, after 9/11, as was mentioned by my generous introducer, I spent a lot of time with police and with fire personnel who had been involved in 9/11, and they had a lot of post-traumatic stress disorder. But it's no longer considered under anxiety disorder because the DSM-5 committee felt it was so important that they created a new chapter on just trauma-related disorders. And this is not just post-traumatic, a couple of disorders in there. And that's very important. And what we're learning in clinics is there are a lot of children, especially, who have been exposed to abuse or to traumas. And so it's something that we have to look at. But it's no longer considered an anxiety disorder, but it's a very important thing. It's a very important thing to think about when we're thinking about anxiety disorders. Similarly, obsessive compulsive disorder has its own special DSM criteria now, and that's included in this new chapter on impulsive compulsive disorders. And an impulsive or compulsive disorder is where I have a sudden impulse to do something, or I feel compelled to do something. In other words, sometimes I'm driven to do something, or I feel absolutely compelled. I have to go back and I have to check the gas is off. Even though I've checked it 10 times, I've got to check it again. That's obsessive compulsive disorder, and that's where I feel compelled to do that. So those are the related disorders. Well, is this common? Well, there's estimates that in children and adolescents, up to 8% of them are walking around with some kind of anxiety disorder. And often people are anxious. One of the things they're anxious about is not exposing themselves to the public sphere or to other people's scrutiny. So they don't want to talk about their anxiety disorder. So this can be hidden. What are some of the symptoms that parents, teachers, and clinicians should be aware of? Recurring and increasing fears, worries about routine parts of the day, kids who are worried about going to school because our kid's going to make fun of their clothing, physical complaints, sometimes, especially in families where they're not used to talking about feelings, anxiety disorders will show up in physical complaints, stomach aches, headaches, trouble concentrating, trouble sleeping. So the child may not say, or the parent may not say that the child is anxious because they're not aware of the speaking in psychological terms, especially in rural areas where people are very practical and they don't think about their own internal psychological state so much, but it may show up very prominently as physical symptoms. There are other symptoms we should be aware of. And this is just symptoms continued, a continued list here. Fear of social situations, fear of leaving home, fear of separation from a loved one and refusing to go to school. These are obviously quite related to each other. And these are fears with kids have. You all are aware, if those of you who are in the pediatric practice are very aware of school refusal, children who are very afraid of these kinds of things. So I remember my own son, who is now grown, thank the Lord, and he had a terrible fear of needles, and he was a pretty well-behaved child otherwise. But when he was about 5 years old, he was in the doctor's office, and they told him, "Okay, now we have to come back in a second, give you a shot." He ran out of that office, and he ran 2 blocks before I could catch him. And this was not a child who would ever do that kind of thing, but his anxiety about the shot was so intense that it led him to behaviors that were unusual for him. Eventually, he got over that, and we got him back safely. But it was very dramatic how that fear led him to avoid the shot. And one of the things we're going to see is very important to understand is that avoidance, right, is one's reaction to anxiety. The reaction to anxiety is to avoid a situation. And if you understand, if you run into a child who doesn't report any anxiety symptoms, but seems to avoiding a lot of things. They're not going to the regular parties. They're not doing the things that other children their age are doing. You might be dealing with an anxiety disorder because avoidance is a prominent reaction to anxiety. As you all know in your own lives, things that you're afraid of are things that you avoid. It's very important to think about these 3 these three overarching categories, which we're now going to cover: developmental considerations, separation from primary caregiver, situational anxieties, which are developmentally appropriate. That means that they occur within the developmental situation. We'll talk about that in a second. It's important to do a differential diagnosis, to recognize the difference between a primary anxiety disorder and medical conditions, also other psychiatric conditions, substance-induced issues, and make sure that we can sort those out from anxiety disorder. And once we've sorted those out, figuring out which anxiety disorder it is. Although, while we have these disorders, the diagnosis of trying to figure out which anxiety disorder can be difficult, and sometimes it's not. Sometimes it's important, and sometimes it's not, because you know the child is anxious, and among children, there's some fluidity across these diagnoses. So let's take a look at this chart. What this says is that anxiety is going to take place during infancy, preschool, middle school, adolescence, and youth in different situations, because there are different kinds of inciting situations that might provoke the anxiety. In infancy, it's the parents leaving. In preschool, it might be social interactions with other children. In middle school, you might have performance anxiety. So how anxiety manifests depends on where the child is in their developmental state. Now, some of these anxieties are normal. It is normal for a middle school child who hasn't done a lot of performance anxiety, where they're suddenly having to get up in front of a class or in front of the school, a school conference, and talk. Is absolutely natural. In infancy, it's somewhat natural to have separation anxiety. The question is, how much are you having? When does it become abnormal? So when you're thinking about anxiety, ask yourself, how old is this child? What are the life challenges at this stage of the life? And are those manifesting in a normal or abnormal level of anxiety for that child? Well, how do we differentiate from physical disorders that may mimic anxiety? Just be aware of these. Hyperthyroidism, caffeinism in older children, that is getting into the habit of drinking a lot of coffee. And that's a situation I'm in right now. I drank a lot of coffee before coming here. It's not making me anxious, but I think it might make me talk faster. But that might be because I'm from New York. So caffeinism can be a source of anxiety. Kids don't realize how the caffeine is affecting them. And these days, you have all of those power drinks everywhere. The kids can just bow these power drinks, and they have a lot of caffeine and a lot of stimulants in them. So that can be the cause of anxiety. Migraine headaches. Sometimes there's a kid who has migraine headaches, and he knows that they're coming, so he's very anxious. But that's the primary problem, right? Asthma can cause anxiety. Seizure disorders can. There's something called pediatric acute neuropsychiatric syndrome, and that is an actual brain disorder called PANS, and that can present with anxiety, with OCD. Lead intoxication can also be a source. Now, less common are things like hypoglycemia, low blood levels, CNS disorders, pheochromocytoma, which is an endocrine disorder. And if there are cardiac arrhythmias, we are aware of cardiac arrhythmias, and they can cause a child to feel anxious. But you don't want to miss these underlying. The idea here is there may be underlying medical conditions, some serious, some less serious, but those might be driving what looks like anxiety. So be aware of them, make sure those are not what's going on if a child presents with anxiety. What about alternative psychiatric diagnosis? Absolutely. ADHD, there's restlessness and inattention, and that can be misinterpreted as anxiety, but it's actually ADHD. Psychotic disorders, if a child is having visual hallucinations or auditory hallucinations or delusions in older children. We're going to talk about psychotic disorders tomorrow. I'll cover all of that. But that can be confused, and it would be terrible to miss that, okay? Autism spectrum disorders can show up with anxiety. Learning disabilities are very important because sometimes kids have learning disabilities. What happens? They can't do the work, and they become very anxious going to school. So if they're misdiagnosed as having an anxiety disorder and someone treats them with medication for an anxiety disorder, that's not helping their learning disabilities. So that's very important that we be aware of that. I thank God we're living in an age where we're more aware of learning disabilities. But when I grew up in elementary schools, there were so many kids who were missed, who I'm now aware of, who had learning disabilities. And, you know, they were just told that they were bad or lazy, and people did not understand what they were struggling with. Bipolar disorder can show up again with irritability, insomnia, and look like an anxiety disorder, as can normal depression. Very often with depression, though, I want to be clear that depression can show up with depression and anxiety together. So you could have both disorders, but sometimes the primary thing is the depression. And so you want to treat that. Also, some good news there, and not getting confused, the treatments for the depression and anxiety overlap each other. So sometimes you'll have somebody who has both types of symptoms, and you treat the one, the other one goes away because they are closely related. Other considerations we should keep in mind when we're making this differential diagnosis is the possibility of substance abuse. So you want to interview the child alone for this. If it's an older child and who has your trust, you might be able to find that out. You also might get a urine tox screen. And I'm not sure the culture in Guyana as to whether you need parents' permission for that. I can't speak to that, but in the US, we will often get a substance abuse check by doing a urine analysis. You can have something called an adjustment disorder, which has to do with it's like a mild form of PTSD that's adjusting to a difficult situation. But again, remember, you could also have PTSD because of trauma, and trauma can come out because of abuse, because of bullying, or because of a threatening environment. So a kid may be in a school in which a couple of bullies are beating him up every day, and that kid will have anticipatory anxiety. He will anticipate that, oh my God, they're going to hit me today. So he's anxious about that, but he also may have PTSD because he's already been hit, and that's causing him to have PTSD. Pregnancy, don't forget that pregnancy is something that an adolescent may be aware or not aware of. Either way, they may be very anxious. Now, prescription drug side effects, anti-asthmatic, steroids, even SSRIs, which are there to help with anxiety, can cause anxiety symptoms. So be aware of those. And then there's these non-prescription things, diet pills, antihistamines. As I said, some of those power drinks that the kids are just buying over the counter, and they have no idea that these things can cause them to be very anxious. So ask these kinds of questions. One way to assess when someone shows up with an anxiety symptom is, this is an old American mnemonic. I don't know if it's used in Guyana. It's called the Calder, and it's a way of going through and evaluating a symptom. Kind of I call it the archaeology of a symptom. What are the characteristics of that symptom? What makes it come on? What's the onset of it? What is its location? Meaning either location in the body, I have a stomach ache, I have tremors, or its location in which it happens. How long does it last? What is the exacerbation? And what is the relief? What helps it go away? If you could understand that, you can often get a long way towards understanding what the anxiety disorder is. If someone tells you, oh yeah, it only takes place in school. When I'm outside of school, I don't have this anxiety. Or it only takes place when we're driving in the car and we're coming near to a bridge because I have a specific fear of bridges. So it only takes place when we're around bridges. As soon as I get off the bridge, I feel more comfortable again. So asking these kinds of questions about the presenting anxiety symptoms will help you sort out which one it is. So if you have an impression, or we're going to talk about screening tests in a moment. So if the screening tests point me to anxiety and I have reason to believe that anxiety, then I'm going to follow up with an assessment tool. So there's going to be two steps, a screening tool and an assessment tool. And the assessment tool is going to help me figure out which anxiety disorder it is, how severe the anxiety symptoms are, and how much functional impairment there is. I'd like to bring your attention to these three, because when we think of diagnosis, it's not just what is the diagnosis, but I also want to know the severity of the symptoms, and that's one thing, and then functional impairment. Now, severity of symptoms and functional impairment are different. This gets confused sometimes. I can have a very severe thing, but with a kid who's sort of very resilient can have very bad fear, but he nevertheless overcomes them and he goes to school. Well, you want to treat the symptom because he's functioning well, but he may have very uncomfortable symptoms. On the other hand, there may be somebody with relatively mild symptoms but it's completely stopping them in the tracks. And they have large functional impairments. So they only get a little anxious around other kids, but it makes them completely avoid social situations. That would be low severity, high functional impairment. So you can have it either way. So how would we do, having this background, how do we do the assessment? Looking at one case example of Sue. She's an 8-year-old girl in the 3rd grade. She comes in complaining of stomach aches, feels uncomfortable with peers in school, but mostly she's complaining, I got stomach aches. She is also tense when her parents discuss her schoolwork with her. Notably, she mentions that there's no stomach aches on the weekend. She's not particularly outgoing child, but she does have friends, so she's not isolated. Well, what are we going to do? We're going to use mental health, this should say assessment tools. We always start with a screening tool. And the screening tool that we recommend is the PSC-17, although there are other ones that you may use in your practice. I discussed this yesterday. I don't know how many of you were here, but we discussed the use of that, but I'll go over it again now. In the PSC-17, and by the way, it's very cleverly named because it has 17 items. So in the PSC-7, and by the way, it's totally available free. You can download this. It's in many, many languages. And so it's really easily obtainable. Most of the things I'm going to talk about, I talk about it because they're easily obtainable. You can get these things. Okay. So you rate each item as never, sometimes, or often, which gives you a 0, 1, or a 2. Then you have the total score. You just add up all of the positives. And if it's greater than 15, then the child has scored in. In other words, positive for some mental problem if they have greater than 15. About 12% in middle class practices in America, about 12% of the children will score greater than 15. Those are just random kids who have come in for a well check or they've come in for a runny nose. About 12 of them will score higher than 15, which means that they score in. In poorer neighborhoods, it's higher, but there's less research done on it, as we know that happens. So we're not sure the numbers in poorer neighborhoods. Now, the way that the PS-17 works is that the different questions relating to different kinds of problems are mixed up in it so that the people can't game it. They can't figure out what the particular question is completely getting at. And the way that they sort it out is that next to each question, as I'll show you in a second, is one of these 3 symbols, diamond, square, or asterisk. The diamond is for those questions related to attention. But again, you're going to see that the person filling this out doesn't know that. The box is related to externalizing disorders and the asterisk to internalizing disorders. Now, in child psychiatry, we make this distinction, and you don't do this so much in adult psychiatry. Externalizing symptoms are those kinds of disorders which manifest externally. Kids have bad behavior, they are out, they're getting into fights, they're irritable, they're angry. That's an externalizing symptomatology. Internalizing symptoms are more the things where the manifestation is mostly inside the head and the heart and the body, such as anxiety and depression, worry. Those kinds of things are called internalizing. So in pediatric psychiatry, you have these 2 big categories, externalizing and internalizing, and another category for attention problems. It's a good way to divide the world into to divide the pie of mental health into 3 easily understandable categories. Now look, here is the scale, and you'll notice next to each question is either a diamond or a square, so that I can, when the child fills it out, they don't notice this, and they just fill it out. They say never, sometimes, or often, but I can go back and say, okay, what are all the diamonds? What are all the squares? So here's, you can see what happened is that to make it easy for you to see this, we've circled all the diamond things, and that's going to be a total of 6. And we've totaled all the externalizing disorders and externalizing questions, and those turned out to be 0. And the internalizing questions were a 9. Let's look at some of these internalizing questions so we understand it better. Feel sad or unhappy is one of them. Feels hopeless is another one of them. Down on yourself, not having fun, worries a lot. So you see, these combination of these are the ones that give you an indication that you're in that thing. Well, let's look at Sue's score. First of all, she's greater than 15, so she scores positive. She's got something. Second of all, when those are the attention score, it has to be over 7 to score in. She comes close, 6. The externalizing, she's a 0. Internalizing, she scores 9. 5 is enough to score you in. So very suspicious for an internalizing disorder, maybe depression, maybe anxiety. But I also know her story. She's told me what's bothering her, or her parent has. So I'm leaning towards anxiety. This is a nice little flow chart that shows you the 2-step process that we recommend for using screening tools. First, we use the PSC-17, and we see if there's a total of 15. Then we look at the subscales: inattention, externalizing. Oh, for her, I have positive PSC and I have an internalizing. But I also know that she presented with anxiety symptoms, not depression symptoms. Yesterday, we had the PHQ and the Columbia Depression highlighted because the presenting symptoms were more depressive. But in this case, they're more on anxiety. So we're going to look at the scared. Now, scared is not the word scared. Scared stands for an assessment tool for anxiety. We'll see it in a second. So this slide says what I already said. And it just tells me at this point, I've done these things. I've done the pediatric symptom checklist. I've seen that what it is. So I have to move on now to the scared screening tool. It's called scared because it's a screening for children, adolescent anxiety related disorder. It has all DSM-5 anxiety symptoms are listed, all of them from all of the different anxiety things, the total sums versus the individual disorder. So it gives me a total score. I know whether or not I have an anxiety disorder, but also there's a way of grouping just as we had before with the diamonds and the squares, there's a way of grouping them together to give you the individual type of anxiety disorder, as you'll see in a second. It can be filled out by a child 8 or older. We recommend between 8 and 11, the clinician should help the child. There are 41 items, and therefore you can have a total score, because scores are 0 or 1. So you can have a total score from 0 to 82. A score over 25 indicates the presence of an anxiety disorder. A score over 30 is even more specific. Now, just take a look at this for examples, and the instructions come with the tools. So don't worry, you don't have to memorize anything here. You can just look it up, and it shows you which items, if they're positive. So you look at the total score, and then you look at these subscales. So this gives you the list of the subscales for panic disorder. And if it's more than 7 on panic disorder, then it's very likely they have panic disorder. Now, again, you've got to talk to the child. You can't totally rely on these scales, but they're very, very helpful. Here is a subscale. All of these items are subscale for generalized anxiety disorder, etc. Also, significant school avoidance is scored by these items. And the rule is if you have more than 3 out of these items, then that's an indication of school avoidance. Here's the scale itself. Let's just look at one of the questions to get some idea of it. When I get frightened, I feel like I'm passing out. Well, maybe that's going to load onto panic, right? Again, you just have the scoring symbol down here, telling you exactly which ones to accumulate together to make the subscale diagnosis. And so you get an overall score for diagnosis, and you get a hint as to which, and I'm saying it's a hint, it's a strong hint, but you also, again, always, I want to emphasize, you've got to go back and interview the child. What some people like to do is that they'll have the child fill this out, and then they'll look at all the positives, and just their interview just consists of asking them about that question. This is very simple, especially for primary care docs who are not used to doing in-depth psychiatric interviews. Don't worry about it. You can have the child fill this out, and then you can say, oh, Sue, I see that you said that you worry about things not working out for me a lot. Tell me about that. You see? So you can say, I see that you said you worry about what's going to happen in the future. Tell me about what is it that you're concerned about in the future. So this is a way of being able to use this as a guide to your interview. When I get frightened, I feel dizzy. This is scored no. So you say, oh, I'm so glad to hear that even though you have this anxiety, you're not getting dizzy. So you can talk about each of these, of course, focusing on the positives. What happened with Sue? She had a total score of 32, which again is bigger than 25 and bigger than 30, strong indication for an anxiety disorder. She had positives like this. Her score on the school avoidance subscale was an 8, cutoff is 3. So schoolwork has got to be a central problem for her. Generalized anxiety disorder, she had 13. Somatic symptoms, she had 8. So in this case, it seems like it's pulling me towards different anxiety disorders that she may have. An interview will help clarify that. But again, sometimes some of these will be overlapping. However, look at this. Social anxiety score is less than 5. Is 5, which is less than the cutoff of 8. And it fits perfectly with the history we said. She's got friends. She's not a big social person, but she has friends. And so that's not an area of real concerns. Separation anxiety, not a real big concern. In fact, what makes her nervous is that her parents are always judging her schoolwork. So it's not a separation anxiety from them. It's actually their presence that's making her anxious. So it's beautiful to see the way these answers on these carefully constructed questionnaires work very, very well with the history that you're getting from the child. Just a summary here. So you do want to review the relevant history, the past medical story, assess the functions. How is this affecting you? Remember, we talked about functions and symptoms. It's also important to assess the safety, especially if you're going to start to use SSRIs. You want to make sure that there's no self-harm going on or suicidal thoughts. You want to make sure that there's no trauma. Now, let's talk about the trauma for a second, because 1 in 4 American children have had a traumatic event before the age of 16. That's a pretty startling number, right? To say that 25% of the kids have had some kind of traumatic experience. Now, not every time does a traumatic experience lead to PTSD, right? Sometimes you have a traumatic experience and the result is depression. As I said, in our 9/11 sample, the result was separation anxiety. But it's very important to look for these traumas. PTSD is going to consist of 2 things: the exposure to the trauma. And here's a good way to asking about it. Has anything frightening or dangerous, either recently or ever, happened to you or to your child, depending on who you're talking? So that's a very nice question. I recommend people have those kinds of questions formulated in their head, because sometimes it's uncomfortable to talk about these things. Has anything frightening or dangerous, either recently or ever, happened to you, Sue? You can ask that question, right? And you also want to see symptoms. So it's the exposure to the trauma, and what were the symptoms? What happened to you after that trauma? Did you notice a change in anything in your stomach aches? Did you notice a change in your anxiety? How does traumatic stress symptoms appear in kids? And again, we're talking about trauma because it's closely related to anxiety disorders. But again, right now, it's not technically called an anxiety disorder, but that's more of a technical point. When you're talking about anxiety, you also want to cover post-traumatic stress. You want to make sure that you are aware of trauma, especially ongoing trauma in a child. So the 3 big categories for PTSD are re-experiencing, when people they can't help it, but they're constantly re-experiencing the trauma because of thoughts are coming to them. Imagery, misperceiving danger, nightmares. Avoidance, we talked about. Avoidance is big in PTSD. When I treated firemen, a lot of them were fearful of going into burning buildings. Some of them were fearful of going into elevators, even in a normal building in the middle of the town. They couldn't go into elevators. This was a fear that they had picked up as part of their PTSD. For obvious reasons, I would say. Avoidance can also present itself, not that I don't go someplace, but in this notion of dissociation. Kids who seem separated from themselves, right? The clinicians will be familiar with the idea of dissociation. For the rest of you, it's this notion of being separated from yourself, like you're there, but you're not there. You're outside of yourself and you're watching yourself, or it's feeling of numbness. So trauma, that's very important. And then if you do identify that, trauma-informed care is very important, because if people live with long-term trauma, it disrupts the immune system. We're actually doing research on that on our 9/11 kids now. More easily end up being smoking or alcohol problems. Why is that? Well, people need distractions. If they're anxious all the time, a 17-year-old who's anxious all the time may come to recognize that a little bit of alcohol reduces the anxiety. Well, that's a strong driver, right? Increased problems of juvenile justice and chronic health, physical health problems will all take place if we miss trauma and the child is forced to live with the traumatic symptoms over many years or decades. I think that kind of covers the assessment part. I hope we feel comfortable with that. Let's talk about the treatment. And by the way, these treatment slides are adapted from ACAP practice parameters right here, the assessment of children during the Journal of the American Academy of Child and Adolescent Psychiatry, 2007. So you might want to jot down that reference. And if you don't get a chance to jot it down, you can always get in touch with us. We'll give it to you. So that's a good reference from which it hasn't been updated to my knowledge since 2007, but it's a nice reference on how to treat. Well, treatment has two important things to think about. First line of treatment for anxiety is cognitive behavioral interventions. So a special kind of psychotherapy. We've discussed yesterday, not any therapy. You can't just say, oh, go to a therapist. You know, we have to know that it's somebody who's doing cognitive behavioral therapy, a specific kind of therapy. Treatment planning, when you do that, it should be considered multimodal. In other words, I send the child to a cognitive behavioral therapist, and I also educate the parents. I do consultation with school. So it's a full wraparound treatment. The child is getting CBT, and the people around the child are being made aware of the problem and how they can help. That's first line treatment. Now, we'll talk about when we switch to medication. Pharmacotherapy is, of course, used, and we're going to talk about that in 1 second. But I want to make a caveat that if these treatments don't work after 6 to 12 weeks in your treatments, then it's time to call in a mental health professional. Our whole goal here is to keep more of mental health treatment in the primary care setting, but you got to know when it's over your head and you need to call in a mental health professional. So if you do some of the things we recommend, but it's not going well after 6 to 12 weeks, do a consultation. I know that many of you are concerned about CBT. Let's talk about what CBT is. But I understand that many of you will say, Dr. Amsel, we don't have CBT therapists available to us. And I'm aware of that. And that's very true in many, many places in the US as well. What's important is that we know what the evidence-based treatment is right now, and we work towards having greater availability for it. And then we'll talk in a moment about what to do when you don't have a CBT therapist. What is the cognitive behavioral therapy? It explores a relationship between thoughts, feelings, and behaviors. It's sometimes very hard to control behaviors, but if I control my thoughts, if I control my thoughts, that's hard too, but I can fight back with my thoughts. If I say, oh my God, if we drive over this bridge, the bridge is going to fall down and I'm going to die. You can use counter thoughts to say, no, I've driven a bridge many times and it didn't fall down. So you can use counter thoughts to counter your thoughts. Feelings are the hardest thing to change. You've got to change them indirectly. You got to change your feeling indirectly by changing your thoughts and changing your behaviors. These cognitive behavioral therapies are not those kinds of psychotherapies that we hear about in big cities where people are, for example, a Freudian style therapy for years. They're very short, 12 to 16 weeks. They're very goal oriented. The patient completes homework. There are relapse prevention plans built in. And there's not one cognitive behavioral therapy. There are different cognitive behavioral therapies for different kinds of disorders. For example, the cognitive behavioral therapy for post-traumatic stress disorder involves a lot of exposure, and it's different than the cognitive behavioral therapy for depression. But all of them include psychoeducation. And by the way, psychoeducation is so important. It just sounds like a catchphrase, but it's so important because people, especially in anxiety disorders and depressive disorders, if they understand their disorder, that's half the way home. With my firemen, I used to always tell the firemen, because they said, Dr. Amsel, I think I'm going crazy because I know that elevator is safe, but I can't get into it. So I think I'm going crazy. Here's what psychoeducation does. Explains to them that your brain has multiple parts to it. And you're not going crazy, but your fear system is dominant at the moment. So I would tell them, listen, every morning there's a committee that meets, and the committee decides how you're going to feel and what you're going to do. The committee decides when you're scared and when you're not scared. And by the way, you're not invited to committee meetings. What do you mean, Dr. Amsel? Say, well, you're not invited. Your brain makes this decision, but it's not interested in what you think or believe. That's your fear system taking over. Oh, wow, doc, now I understand. So they feel much better. It's also important to mark somatic management. Remember, we talked about anxiety disorders. manifesting in physical symptoms, there are ways, breathing, exercises, muscle relaxation exercises. There are ways that they can do the somatic management. There's cognitive restructuring. That's what I told you. You learn how to identify your catastrophizing thoughts and you counter them. The bridge is not going to fall apart. It doesn't help the first time you do it, but if you do it a lot and in the right way, this is going to help. I already mentioned exposure-based CBT. That means where I expose myself to the thing I'm most afraid of, or expose myself even to my own memories, which is one of the things we found with the firefighters. I don't want to go back and remember the 9/11. Well, we have to go back and remember that, because I expose yourself to your fearful memories, you stop being afraid of those memories. Okay. We've actually gone over the slide, the exposure therapy, we've explained the cognitive restructuring, we've explained, and the somatic management is teaching kids how to manage their physiological symptoms. You can learn how to do a breathing exercise in 10 minutes. You can learn how, and there are hundreds of different kinds of breathing exercises, and they will have a good, powerful, short-term effect on anxiety. It'll sometimes break an anxiety or a panic if the patient does a good breathing exercise. Well, Dr. Amsel, we don't have any CBT things. What can you do? Well, first of all, if it's possible, encourage your parents to have their children engage in CBT. And by the way, there's evidence that you can do CBT online right now, sometimes with a therapist, but sometimes even just with a program, where there are online programs that walk you through the steps of how to restructure and how to do these things. So CBT is available in many forms. If you are using a therapist, make sure that they do CBT treatment. The psychoeducation materials, like the thing I just mentioned about explaining to people if they have a split brain and they're not going crazy, but that their fear system has taken over, that helps. Teach relaxation skills. And there's something called Coping Cat. Please write that down. And that's a workbook that children can use, Coping Cat. Here's a resource slide. We can get this to you if anybody wants. You can email us and we'll get you these things, because we don't have time for you to sit on that and have it copied. Sorry. Now remember, mild severity should begin with psychotherapy, but there are valid reasons now for introducing medication. And those are, and when you want to introduce medication, you want to combine them. So if there are acute symptoms and the patient is too uncomfortable, you can't wait for the therapy to work. If the child is so impaired that they can't participate in psychotherapy, or if they have a comorbid disorder, or if they tried psychotherapy. So in all these cases, you may want to add medications. What are the FDA approved medications? For OCD, it's these, fluoxetine, and sertraline. Also the TCA clomipramine is FDA approved. For generalized anxiety disorder, the SNRI, that is serotonin and norepinephrine reuptake inhibitor, that's what that sounds like. That's Cymbalta, and for kids over 7, that is available. Well, what's the efficacy? Is there any efficacy, any data on efficacy? The answer is yes. The RUP study showed that fluvoxamine was better than placebo. In the Pittsburgh anxiety study, again, fluoxetine was better than placebo in these anxiety disorders. And the combination of therapy and CBT was better than CBT, which was equal to sertraline, better than placebo in the POTS. So these are just examples of and the CAMS is another example. These are just federally funded large studies that proves that these SSRIs do have good efficacy results. And here's some of the details about those studies. So when you start medication, the important thing is to educate the family, start low, go slow. Begin with a small starting dose, and if no side effects, you can move up and continue to monitor for those side effects. Get baseline rating scales and follow up with continued rating scales. So go back and look at the scared. Ask them to refill out a scared after 3 or 4 weeks of medication. I want to see how that scared has changed. Here's again is a chart. What the starting doses are. So for example, for fluoxetine, it's going to be 5 to 10 milligrams starting, increments of 10 to 20 milligrams. Here's the effective dose, and here's the maximum dose. And this chart's available. So after you've done a very careful assessment, including using the two-step tools, the screening tool and the scared diagnostics tool, you've done a physical exam and laboratory. Think about what you're going to do if you're going to start medication. What medication am I going to choose? I have some choices. What will be your starting dose, and what's your therapeutic target? Oh, kids going to school now and not avoiding school. Make sure you have a specific target. Now, a lot of people are using anxiolytics, benzodiazepines. In children, these are not first-line treatments for child anxiety disorder. A lot of these ancillary things, beta blockers, they can be helpful. Antipsychotic drugs are sometimes used in anxiety. That's improper. But a lot of people do use benzodiazepines. But it turns out that in the benzodiazepines, there are no evidence, no evidence has shown that they really help anxiety disorders in the long term. This is a confusion for a lot of clinicians because they know if I give Ativan, the kid's going to feel much more relaxed. And that's true, but it's like a Band-Aid. It only covers up the symptoms, whereas the SSRIs get underneath and actually affect the underlying anxiety disorder and reduce the anxiety disorder. May not completely cure it, but it reduces it. Whereas these medications, you've got to take them over and over again every time you're anxious, and they have addictive potential. So it's very important that you start out using the SSRIs and not use the benzodiazepines. There are times when for a short time while you're waiting for it to work, in some older kids who are not substance abusers, that may have some special uses. But in general, our recommendations are CBT and SSRIs. So be on the lookout. Anxiety disorders are everywhere. There's comorbid disorders to make sure that you're ruling out. Use our standard tools to help you make the assessment. And then for treatment, use CBT or SSRIs. The good news is these anxiety disorders are very treatable. You will be surprised using these steps how many kids get really better. There's some resource slides, and again, these we can make available to you. But now I'd like to take the rest of the time to take audience questions. And thank you for your attention. I think
Dr.
somebody else will
Amsel.
monitor and direct the questions to me, right?
Thank you, Dr. Amsel. Does anyone have any questions for Dr. Amsel?
I have a question. Hi, Larry. Ellen here. Thank you for that wonderful talk and such a thorough explanation on how to assess and treat anxiety disorder. My question is, in a culture where skills, can you hear me?
I hear you perfectly well, yes. Good morning.
Good morning. My question is, for a culture sometimes where they would prefer skills, not pills, can you present to us anecdotally some observations of what we would see in a child who, just observations, what you would see in a child treated with the SNRI or SSRIs for anxiety disorder versus a child who would not? What would be the benefits that will be observable?
Well, you talked about cultures. I think that I've just indicated that that's my culture. My culture is let's start with psychotherapy, except in special situations where you have to. But psychotherapy is going to be the first line of things. So I'm in that culture. I'm in that culture, and the evidence is in that culture that for mild to moderate anxiety, if it's severe, you may need those. And the answer is, if a child is treated with SSRIs or they're treated with CBT, very often you couldn't tell the child's improvement. You'd notice that the child was improved, that the anxiety disorders, will have gone away, that the avoidance behaviors have gone away. So then you may not notice a difference between, two children coming in parallel, one getting medication, one getting CBT. What's the difference? The difference is that the kid who gets the CBT has skills on top of it, right? Their anxiety disorder has gone away, but they have skills for other problems that come along, right? They have learned some skills. They have learned one of the most important life skills there is, how to monitor and change my own thoughts and feelings, right? So those kids are more empowered. The medication doesn't empower you. It takes away the anxiety disorder, but doesn't empower you. So that's the way you would see a difference between between those. But then there are some kids who are just too anxious to start the CBT. They need medication to get a little bit less anxious, and then the CBT takes them all the way home. So there are different circumstances, but I think that, I hope that answers your question.
Yes, thank you. Thank you, Dr. Amsel.
Dr. Amsel, I also have two questions for you. First and foremost, thank you so much for the presentation. It was wonderfully done. I was able to follow along with everything that was said.
I'm glad to hear that.
Yes. First and foremost, I know that we're dealing specifically with children, but can these tools be used on adults as well? The PSC 17 and the SCARE tools?
Yes, yes, they can be used on adults as well.
Okay, and for disorders, we know that disorders is different from just having minor anxiety about, something that would have come up. So
Right.
in the case of a disorder, do they vanish completely? Is it possible that they go away completely, or do they just become manageable with time?
Well, I think if you do a good course of CBT, then you can actually get an anxiety disorder to go away. But even if it doesn't completely go away, if you reduce the symptoms, you're still doing a lot of good. But oftentimes with a good course of CBT, it can go away. When we treated those cops and firemen who were healthy right before 9/11 and then got PTSD, in those cases, it went away completely for most of them. So we got real cures in that case.
Okay, thank you so much. Does anyone else have any questions for Dr. Amsel?
Well, you can always,
Okay,
anybody, I always say, once my student, always my student. You can always get hold of me at my email or through the GPEG at Columbia, and I'd be welcome to happy to answer your questions and to move on. So
okay.
I'm going to
Dr. Amsel?
yes.
Excuse me? Yeah, we have two questions from the chat. We have Miss Nicole Cole asking for you to speak to the effectiveness of DBT, that's dialectic behavioral therapy in children and adults. Is it used together with CBT?
Dialectic behavior therapy is a very, very good therapy. It's not for anxiety disorders. That is to help people who are cutters, who are self-injuring themselves, or have some serious personality disorders. So it is a very good, effective treatment, but it's not for anxiety disorders. It's for other kinds of problems. And I have to go. I have one more minute. I'm sorry, I've got to leave 1 minute early because I'm giving the next talk as well. So
right,
one last question.
We have one last question from Ms. Padmini. She's asking, she says she also agrees with the CBT first approach, but as you mentioned, they may not be therapists skilled in CBT depending on the location. Are there tools and resources online that you can recommend for PCP to learn CBT?
Yes, in fact, one of the things that our organization does is we teach primary care clinicians how to do CBT, which is actually a course you can learn it. It's not hard. It just takes a lot of time when in the office that a lot of people don't have. But the resources that I put up, we can say, if you get in touch with us, we can get you some of those resources. The lists I jumped right through them, but there are those lists, and like I said, there's a lot of information online. So even before you get our things, if you just go to cognitive behavioral therapy online, you'll see there's lots of resources online for cognitive behavioral therapy, for training for cognitive behavioral therapy, and even for just stuff you can do online. A child can go online and interact with CBT programs that teach them these skills. So things are getting better. I want to make one point. If you absolutely don't have a CBT therapist, use the medication. Sometimes you have to use the medication because you just don't have the perfect resources. And remember, the worst enemy of a good plan is a better plan. So don't withhold the medication to a child who's very anxious because you can't get them to a CBT therapist. That's one of the reasons when it becomes legitimate to use the medication and make sure the child gets at least some treatment, and that will help them. And then we hope that this new Guyanese project of mental health, that we will increase the number of available CBT therapists and work together to do that. So
okay, again, thank you, Dr. Amsel.
You're very, very welcome. I'm sorry to
for your
sound rushed at the end, but I do have to get to my next session. Thank you all for your attention and for coming here. And again, once my student, always my student, feel welcome to contact me at my email. God bless you all. Have a good rest of the day.
Thank you, everyone, for your attention and your participation in this talk. Bye, everybody.